So we need to think about the complications of hypertension because this emphasises why it's so important that we can treat it at an early stage. And the first thing I think I'll talk about is the arterial damage. So hypertension can lead to arterial damage. Now this can affect two types of vessels. First of all, the small arterial type vessels, vessels less than 1 millimetre. Now, in the small vessels, it causes a hardening, a sclerosis, and this is called arterial sclerosis. The hardening of the small vessels, arteriosclerosis, because it's the arterioles that are largely affected. And of course it affects larger vessels as well, the larger arteries. And in the larger arteries, the main problem is the accumulation of the atheroma. Atheroma accumulates in the large vessels, and you might remember this is called atherosclerosis. So arterial sclerosis in the smaller vessels, atherosclerosis in the larger vessels. So collectively we can see that there's going to be damage to the arterial supply to tissues. So we could kind of group these together really as blood supply issues, arterial damage. But why is this important? Well, there's lots of reasons. One is that it can affect the renal vessels. So the first is this can affect renal vessels. Blood supply to the kidney. And over time this will cause a condition called nephrosclerosis. A hardening of the kidney. The whole kidney becomes diseased. And it affects the kidney at all levels, at the macroscopic level, and it affects the glomerular level as well. You remember the glomeruli in the kidneys that are responsible for the filtration. It can affect the kidneys at the macroscopic level as well, the larger vessels in the kidneys, and even the renal arteries themselves. Before the blood supply gets into the kidney, there can be atheroma of the renal vessels. And collectively this leads to a situation of renal hypoperfusion. So there's reduced blood supply to the kidneys. So renal hypoperfusion, hypo, low, perfusion, the blood going through. And this is going to result in reduced renal function. So there's going to be reduced renal function from all of this. First of all, the damage can lead to proteinuria. Protein in the urine. And this is a major cause of chronic kidney disease. Chronic kidney disease, what we used to call chronic renal failure. And of course this is a cause of death, make no mistake. But going back a bit, the renal hypoperfusion, when the kidneys aren't perfused enough with blood, they produce more of a substance called renin. And the renin stimulates the renin-angiotensin system to cause vasoconstriction all over the body and to increase salt retention. So this in turn is going to lead to even more hypertension. So we can see there's a bit of a feedback loop here, the vicious circle, but also leading to chronic kidney disease. Now, The reduced blood supply, of course, is going to affect all of the arteries in the body. The damage affects all the vessels in the body. And this is also going to lead to structural changes in the vessels. In blood vessels all over the body, there's going to be structural change. Particularly, there's going to be a sclerosing, a hardening, caused by the arterial sclerosis and the atherosclerosis. And that makes the vessels less compliant. So normally, when the blood's pumped into a vessel, the vessel's going to go out with the blood supply, and then there's going to be passive recoil to smooth out the blood pressure. But if the vessels become rigid, you don't get these changes. So during systole and disystole, the vessels are only moving a little bit or almost none at all. You get reduced compliance, and this tends to increase blood pressure. So the structural change in the vessels also is feeding back, causing even more hypertension. So we see there's another couple of subroutines, as it were, here. There's the renal feedback causing accelerated hypertension or increased amounts of hypertension, and there's the structural changes. And again, it shows the importance of blocking it at an early stage. You know, if you can block before there's structural changes, if you can treat before the structural changes, prevent the structural changes, and the structural changes can't cause the hypertension. And again, if you can treat the hypertension at this stage, preventing the renal problems, the nephrosclerosis, the glomerular damage, the renal arterial atherosclerosis, not only will you prevent the proteinuria and the chronic kidney disease and the potential death that would arise from that, you'll also prevent the feedback, which is a cause of the hypertension or a secondary cause of the hypertension. So two opportunities there to break vicious circles with treatment at an early stage. Ideally right up here before the damage has occurred to the arteries at all. Earlier you can treat, the better, of course. Now, another classic artery that's going to be affected, of course, are the arteries to the myocardium. It's the coronary arteries that perfuse the myocardium. The right and the left coronary arteries, you might remember. The left coronary artery breaking down into the left anterior descending and the circumflex branch, perfusing the myocardium itself with blood. So if the coronary arteries are suffering from atherosclerosis, if there's a narrowing of the coronary arteries, if there's this accumulation of atheroma in the coronary arteries, this is going to lead to ischemic heart disease, IHD, ischemic heart disease. Of course, one of the leading causes of death in many societies now. And the ischemic heart disease can lead to the acute coronary syndrome. The acute coronary syndrome, ACS, and as you probably know, that can lead to unstable angina. Unstable angina can lead to non-ST elevation myocardial infarction, and of course it can lead to ST elevation myocardial infarction. Unstable angina, more serious coronary syndrome, non-STEMI, more serious yet, STEMI. Another group of arteries that can be affected are the cerebral arteries. The arteries taking blood to the brain, both those outside the cranial cavity, the extracranial blood vessels supplying the brain, and the intracranial vessels, those inside the cranial cavity itself. And again, the main problem here tends to be the atheroma, the accumulation of this fatty atheroma inside the vessels. Now, the atheroma predisposes to thrombus formation, so we can get a thromboembolic stroke. Thrombus is a blood clot where that blood clot forms. Thrombus, of course, is always pathological. Embolic, an emboli or an embolus would be a single, the emboli plural. These are the bits that break off of the thrombus and clot off smaller vessels downstream. This is the most common cause of stroke by a long way. But the atheroma can also lead to weakening of the vessel, and that's aneurysm, a weakening in the vessel. And it's that which often leads to hemorrhagic stroke. Hemorrhagic stroke. Both, of course, of cerebrovascular accidents. Often causing long-term morbidity. The vessels of the eyes can be affected, especially those of the retina, and that can lead to retinal hemorrhage. Blood is spilt into the retina from small vessels, damaging the very, very delicate retina. And there can also be infarction. Cutting off an area of blood supply to part of the retina. So, coronary arterial disease, cerebral arterial disease, eye arterial disease, renal arterial disease, and other renal problems. Now, as well as that, if the blood pressure is high, if the pressure in the arteries is high, can you see that means the heart has to pump harder to get the blood out? And this leads to what we call obligatory high output. In other words, the heart has to work very, very hard because the blood pressure is high. It's pumping against an increased output pressure. Now, if you go down to the gym and work out, your muscles get bigger. It's the same with the heart. If it's working hard over a long period of time, the muscle gets bigger. And in the case of the heart, that's the myocardium. So we get myocardial hypertrophy. This enlargement, this pathological enlargement of the heart, causing enlargement of the heart. Which of course is called cardiomegaly, cardio heart, megaly big. But the hypertrophy will eventually lead on to heart failure because the muscle can only compensate for a certain amount of time. So we get heart failure. This was a cause of failure. And the cardiomegaly and the heart failure are going to make dysrhythmias more likely, so atrial fibrillation becomes more likely, as indeed does cardiac arrest ventricular fibrillation, so atrial. Atrial fibrillation and ventricular. Ventricular. Which of course is a cardiac arrest, that's a cause of sudden death. the cardiomegaly, making those more likely. And of course, we previously noticed we get the ischemic heart disease and the acute coronary syndrome and the STEMI and the non-STEMI. Well, the ischemic heart disease can also lead on to making these problems more likely, so particularly STEMI can lead to heart failure. But generally it's true to say that the ischemic heart disease can cause atrial and ventricular fibrillation, can lead to those complications. So that's partly why these are so common, because there's two pathological routes to the causation. And of course it can also make the heart failure more likely. Again, a bit of a feedback there that another reason we see a lot of heart failure in chronic hypertensive patients. So that's just the briefest of summaries to try and show you the interrelationships between the hypertension and the complications associated with hypertension. Yeah, all on one page. So the key thing is to recognise hypertension by diagnosing at an early stage, thereby preventing the obligatory high output, preventing the arterial damage, preventing the renal damage, the coronary arterial disease, the cerebral vascular disease and the eye vascular disease, and the consequences of those things in terms of morbidity and mortality. And you'll notice that these are all conditions that are really common in Western societies classically, but all around the world now. Very common conditions. So we can greatly improve the health of populations and individuals by recognising hypertension at an early stage. So every time someone comes into a healthcare situation, or nearly every time, or certainly on a regular basis, you want to be checking their blood pressure, making sure it's not going up. And if we think they're at risk of hypertension, giving lots of, well, for everyone, give the health advice, the exercise, the plenty of potassium, the lack of sodium, the not smoking, the restricting alcohol, the good diet, all the lifestyle factors, and if necessary introducing medication, and we can hopefully prevent all of these, and hopefully leave the person with a clean sheet of paper representing good health. Instead of these complications.